So, good morning, and thank you for coming to the first JICA Satellite Session in HSR 2024. This session is on advancing sustainable national health program in Ghana during the transition period. I'm Saida Makimoto, Senior Deputy Director General of Human Development Department of JICA headquarters. And really, thank you very much for coming in the really very first morning of the HSR. And this session will deepen the understanding of Lusaka agenda and the key factors and role of stakeholders to move forward a more comprehensive health system through looking at a case study of Ghana. We are glad to have you join us today and look forward to the insightful presentation and discussion with you. Before start the session, housekeeping announcement. This session is hybrid, so there are about maybe 40 or more participants online, and then I will ask the online participant to write your questions or comments on Q&A section, and I will, in the discussion, I will check your questions and ask to the speakers. And the second one is about recording. We are going to record today's satellite session and upload the video on the JICA YouTube channel later. So when you have a time, please look at the YouTube channel as well. So this morning, we are joined by 4 esteemed speakers from Ghana, Japan, and others who will be sharing their insight with us through the presentation and panel discussion. Thereafter, there will be an interactive discussion with you. Before, and as a background, I want to share the objective of this satellite session. The background. Many countries in transition from low-income country to middle-income status face various challenges in ensuring sustainability of their health system and service delivery as they move away from concessional aid. And transition is not only a challenge, as we observe, but also an opportunity to move forward a more comprehensive health system. And Ghana is a country to be championing of, in sub-Saharan Africa, progressive policies towards attainment of UHC. Ghana has also played active role in many global health initiatives, including serving as a co-chair of the interim working group to take forward Lusaka agenda conclusions. So from this background, this purpose of this session is to share Ghana's strategy and actions for donor transition and integration of donor support program into national health system, to identify challenges and good practice of the preparation and action taken in Ghana for the donor transition, and deepen the understanding of Lusaka agenda and key factors and role of stakeholders to move forward more comprehensive health system. I'm afraid, is there anybody who doesn't know Lusaka agenda? The participants in the room is everybody understands Lusaka agenda clearly. So I don't have to go back to Lusaka agenda. So this is the speakers and panelists. I will introduce to you in detail that there are 4 presenters and 2 panelists. Later, we would like to discuss how can we better prepare the partner countries to exit from donor-initiated project, integrate the proposed MNCH program into national health system, what are the DP's responsibilities for smooth transition, and how can we better participate in the Lusaka agenda? Are there any space role for health system research? So that maybe you can keep these questions, discussion points in your mind, and please listen to the speaker's presentation. Then I would like to move to the session. To start, I'd like to invite Dr. Patrick Abuaj, Director General of Ghana Health Service. He is a Ghana medical doctor and a senior public health specialist. And prior to his appointment as Director General in 2019, he served as a Director of Family Health Division. And he has also played a key role as a co-chair of Lusaka Agenda follow-up process. Now, I pass the time to him to give a presentation on how Ghana government has been fostering country ownership and catalyzing sustainable, domestically financed health services in the transition period from low-income countries towards middle-income countries. So the floor is yours.
Thank you very much. It's a pleasure being here to share with you Ghana's move towards local ownership, and most importantly, how do we ensure appropriate health financing for our services. I'll talk about the current financing landscape, the dwindling assistance for sub-Saharan Africa, and how are we fostering the ownership and catalyzing health systems, and finally, Ghana's way to emerge into the global health initiatives, the Lusaka Agenda has been mentioned. And I'm happy that most people here know a bit about Lusaka Agenda. I had an expert here. I'm sure she will still come back. So just a bit about Ghana. We have about 55% of the population insured on the health insurance, with about $85 per of current health expenditure per capita. The 3.9% of total health expenditure as a percentage of GDP, and about 37% of our people pay out of pocket for health spending. We are a population of 34 million people, 56% urban, and a life expectancy of about 60-61, with about 23% poverty rate. We have 16 regions with 260 districts. We have one of the fastest mobile markets in Africa. We launched our Ghana.gov platform, so there's a lot of digitization going on in country. And we have about 139% mobile phone penetration with 64% internet penetration. These are very important figures that we'll come to see later. How has Ghana evolved from our health financing journey? We had independence in 1957, and between then and 1970, health was supposed to be free. That is free when you get it. So you can imagine how it was. But between 1970 and 1983, through the World Bank programs, Structured Assessment Program, we had to introduce a minimum token. And that actually brought a large toll on the population in terms of access to health. It even got worse when between 1983 and 1990, we introduced the user fees as cash and carry, and that also affected a lot of our data. Our infant mortality rate rose to about 155 per thousand, and we had a total OPD per capita dropping to 0.7. So access to health became a big problem. Subsequently, in the 90s, in addition to the cash and carry, we started practicing some community health insurance to see how it works. And in the year 2003, the National Health Insurance Service Scheme was introduced. How have we gone? Between then and now, we have moved from about a little over 1.3 million people who are registered and clients to about now 17.4 million as of 2023. And our insurance covers, I would say, it's a very, very generous package that covers about 95% of all our services. Recently, we've added 4 childhood cancers and mental health conditions to the package. Children under 18 are free. Those over 70 are free, and all children, pregnant women, are also free of any tariff, of any premium. So what has happened? We've had some dwindling development assistance to the sub-Saharan Africa, particularly Ghana, as was introduced, having moved from low income to lower middle income country comes with its own implications. And you can see from this crowded graph that the red one is the out-of-pocket payment. Ours is coming down. You can also see that the donor support, as the deeper green, continues to come down. If you look at the year 2020 and 2021, in spite of the high inflow of funds for COVID, the overseas development didn't go up, and that can show that there's a major shrinking of donor support, whilst government expenditure in terms of government transfers continues to go up. So it's quite clear that with the trend we are going, if we don't take our own life into our hands, definitely we are not going to be able to, we're going to be left alone very soon. And some of these challenges led to our maternal mortality, even though it's come down, it still remain high. If it's 287 per 100,000 live births. For non-communicable disease, we are having a major challenge with about 5 out of the top 10 diseases are from NCDs. And there's very low emphasis on promotive and preventive services, which are now coming up against. And also, the cost of management of NCD is quite high, and it has a big toll on health insurance. Childhood anemia is high, and the high stunting rate of about 18% for the under 5s. Now, this graph is just an immunization data that to share with you that, yes, we're making progress, but in the last few years, based on the economic challenges, you can see that we are plateauing, I would say, even coming down to some extent because vaccine availability as a result of co-payment, etc., has become a challenge. And so we sometimes have some challenges with our vaccines. And you can see that for those who are not vaccinated, we have moved from 60% in 1988 to 1.6 in 2014. Now we rose up again to 2%. So that shows that challenge creates a problem. So what are we doing to address these things? I hope you can see, I think there are a couple of things that we are doing. We are expanding the health insurance coverage. Now we are working towards enrolling more people, and we are using a lot of digitalization to make it easy for people to enroll. Currently, we have been talking about health promotion and health prevention as part of the package to see how we can also affect this. And of course, efforts are also being made to improve premium collection from the informal sector to make it richer. And of course, decapping as well. We are also improving the health financing. We are leveraging domestic resources through innovative financing strategies and tax reforms. I mean, the health tax. We have been thinking about health tax, and now we also had the COVID levy, which also brings in some resources to support the losses we incurred during the peak of the COVID. We know that we need to be efficient and be also more efficient. So we are building a strong work health force, investing in training, recruitment, and retention of qualified healthcare professionals, even though we've had some major shocks with the brain drain. I think because of the high recruitment, the effect was not as heavy as what we had in the early 2000s. We are strengthening primary healthcare because we know it's the basic, and health system strengthening the basis for sustainability. And so we are focusing on community-based healthcare services and addressing primary needs. We've introduced what we call the network of practice, primarily to ensure that we share resources. We are not just working in silos, whether all the players in health at the sub-district level are being brought together so we can provide services to, and also reduce the burden and the cost of care, as fewer people will be referred to the next level. We are also looking at public-private partnerships in several ways that will also create some efficiency. And improving our infrastructure, we are building a lot of facilities to ensure that people have access to care. And most importantly, we are doing rapid digitalization of our electronic medical records and many other things, digital collection of funds at the hospital to improve efficiency and also reduce waste. But one of the key challenges is making sure that whatever you do is locally engineered and that you have control of what is really happening. And one key example is when we were developing the Maternal and Child Health Record Book with JICA. These were not suggestions from JICA. This was a co-creation between the Ghana and the partners, and we made sure through research embrace, we knew what was the challenges, and we developed that carefully. As you can see, we had to bring a lot of books, documents together. Hitherto, there were about 4 documents managing the same pregnant woman into one book, mainly for each child. And what we saw was that from the findings you hear from the Embrace program, we realized that we use a lot of sustainable client motivation strategies. We did a lot of community mobilization. All players at the primary health care, grandmothers, grandfathers, everybody was brought on board to be. We employed a lot of health system strategies. We involved the private sector. At the end of the day, after many years of struggling with different documents, now we have one document that everybody in the country is using, both public, private. They are very comfortable using that book. It's supply free to all children, mothers and babies. The design is that every child must have one. Yes, it's happening in Japan here. Initially, JICA printed for us, but based on the way it was developed and the way it was accepted, we are having public sector organizations printing, including the health insurance. Some private companies are doing it as a part of their corporate social responsibility. So now we have them in abundance, and every child has one. So we believe that doing that, even to the extent that those who didn't have because we were short, we looked for them and gave them their books. Because if you're under 5, that's your passbook, because you don't have any ID card, and that is your ID card for airplanes and any other places. So what has been our domestic financing strategies? I'm still green, thank God. So looking at all these things, you can see that the essence of the JICA agenda is very, very important, that we need to look at systems where we will help ourselves and take control of whatever we have from the GHI, Global Health Initiatives, and other systems. So the JICA agenda provides the foundation for coordinated action to support these shifts, which I'll talk about, the path towards a joint long-term vision of domestically financed health systems, investor health coverage that leaves no one behind. So that's the core agenda, and I have one of our top researchers here, Claire Battle. Okay, now I'm going yellow. Now, so if you look at the 5 steps, the first one is make a stronger contribution to primary health care by effectively strengthening systems. So, and we also agree that primary health care is the basis for sustainability, and once you invest in it, you are able to make your cost of care cheaper and improve access to all. And we believe that that is an area that instead of focusing on disease-specific area, let's focus on primary health care and health systems. We also have to, the second shift was to play a catalytic role towards sustainable domestically financed health services and public health functions. How do we and how do the partners, GHIs, support systems in catalyzing encouraging us to do more domestically financing services? OSCO also to joint approaches in equity. We have and the fourth lesson gives us a lot of operational challenges. We have different reporting system, different matrices, etc. The cost of services are quite high. So how do we ensure that we create equity, focusing on the vulnerable group and ensuring that we are also being efficient and working together, not in silos? Of course, and I mentioned the strategic operational coherence, and I think I leave more time for explanation as we go into the question and answers. Then how do we finally ensure that we coordinate approaches to products, research and development? How do we do things like manufacture our own vaccines? How do we manufacture our own medicines? We need capacity, we need a system to ensure that we don't always buy, but we are also playing a role. So in a nutshell, this is what the 5 shifts that the Lusaka agenda tends to bring about. There's a lot more that we can do. So these shifts build on some of the work that is already happening in several places, including what I mentioned to you in Ghana, realizing that this shift requires united and collective effort across ethical groups and is underpinned by mutual accountability, both partners and then the countries. And finally, we need all key stakeholders if this is going to work. Development partners, global health initiatives, CSOs, and community organizations are key in ensuring that this SACA agenda, which the road on, that is on the way, continues and becomes sustained. And I know the African Union has endorsed this as a program. We are planning a roadmap for it, and that we're going to roll it out to ensure that all countries abide by these principles. Thank you very much.
Thank you very much, Patrick, for sharing the Ghana's health financing journey and the key government initiative and challenges facing. And also, thank you for introduction from your using your word about Lusaka agenda. It's very important to know that because you are the one of the key leader of Lusaka agenda, so we are very glad to hear from you. Okay, so I want to invite next speaker, Dr. Enrico Ochi Agie-kun, a health economist from the World Bank Ghana office. He'll be presenting us the role of development financing in sustainable health program in transition. He has been working in Ghana health sector for years and currently actively engaged in the network of care or donor coordination, etc. So Ochi-san, now the floor is yours.
Thank you. And good morning, everyone. It's good to be back to Japan. As an alumnus of JICA and also Ghana Health Service before moving to the World Bank. And then also a key part of the MNCH record book process. So we know that development assistance plays a very important role in the health financing in development countries. And it's not only about how much or the quantity, but the catalytic role it plays. And so even in countries where the proportion of donor funding is very low, you find that it is really supporting key essential health programs like vaccination, HIV/AIDS, malaria, and so on. Now, we've realized that development partners adjust their support and eventually exit once countries reach middle income or high income status. The period of transition, however, presents both opportunities, but also challenges. And if it is carefully followed through, it is sort of the time to solidify the gains made from development assistance. But if not, then we are likely to derail all the gains that we've made in the past. Now, the goal of development assistance, we all look forward to move countries from one point to the other. And usually, traditionally, we see it from moving them from low-income country status to middle-income country or high-income country status. And this comes with some distinct characteristics. So moving more from communicable diseases, maternal and child health, to non-communicable disease management, moving from focus on access to care to focus on quality of care, moving more towards a stronger primary health system compared to a chronic bypassing of weak frontline facilities, and then providing autonomy to providers and having the provider purchaser split as compared to the top-down Ministry of Health Management, which is usually found in low-income countries. And then also moving a bit into strategic private partnership, and then also moving away from paper-based weak M&E systems to digitized and then data-driven decision-making systems. And then in terms of accountability, measuring outcomes instead of input, And then in terms of health financing, we seek to move these countries from, donor dependent and out-of-pocket finance into more tax-based and insurance-based financing. And we've seen the example of countries that has gone through these phases, including Argentina, Brazil, China, and more recently, India, Egypt, Indonesia, Morocco, and so on. Now, what have we been doing so far, and why haven't we been achieving much progress in some of our countries? Now, we realize that the issue of donor transition usually will begin after major macroeconomic events. Say a country moved from lower income to middle income country status. But unfortunately, health financing transition is a process and not just an outcome of some macroeconomic event. And development partners will immediately announce some form of transition process to exit or to reduce how much they are supporting the country based on the change in the macroeconomic status. However, macroeconomic transition is not the same as stronger health systems. And so even though a country may move from lower income country to middle income country, it is not automatic that the health system has also transitioned. Now, some development partners also keep the same aid mechanism throughout their support to countries. However, we realize that the transition process can be phased. We can group them into phases. And so using the same approach for many years may not necessarily work. Now, one major problem when the transition dialogue starts is that there's a lot of vertical dialogue. You see dialogue on vaccines, family planning, HIV/AIDS separately, and every one of them want to engage the attention of the Ministries of Finance. Unfortunately, this doesn't work well because the Ministry of Finance have the health sector as just one of their many sectors they are focusing on. So if you come to them with issues of vaccines, yes, it is important, but you may not get the best of the attention. And so there's the need to sort of have a very well-coordinated transition dialogue. Now, there's also sometimes protracted hand-holding, which end up getting countries become donor dependent, and even at the time where they have to exist, the dependent syndrome catches up and they are still holding on to development assistance. So I talked about the phases in which we can see the transition process. So I grouped this into three phases, which are not distinct in a way. There are some overlap, and the country can, be at each of these stages at the same time. But at each point in time, we would see that we'll find one country more belonging to one particular group. Now, the early group is when the health system is very basic, and there is lack of domestic funding for basic input like HR, where donors even have to pay for salaries. And we see this in some of our countries, where vaccines are also fully purchased by donors, a system where the PFM and the governance system is quite weak and even needs support for procurement. Systems where IT infrastructure is very low, such that even expanding critical intervention is very difficult. And then we move on to a bit more developed systems where countries are able to finance their own HR, be able to raise some domestic resources to co-finance their vaccines and also some essential services. And then we move to the final stage where the systems are a bit more matured, and that we see a significant replacement of the development assistance and out-of-pocket expenditure, rather being more domestic financed health system. Now, looking at these three phases, then the development assistance needs to be tailored to each of these phases so that we don't run one program across the transition period. So in the first phase, we may need some hand-holding. They may need there may be the need to have some vertical programs to strengthen particular aspects of the health system. But as we move on, we have to shift from the system support to what we call the system strengthening. So instead of supporting the system, now you begin to strengthen the system in terms of the PFM systems, move away from financing basic essential recurrent expenditures, unless it is very critical, focus on PFM strengthening, and scale up innovative reforms, and deepen engagement on domestic resource mobilization. Then we go into the final stage of the transition where you need to really, really focus on comprehensive donor dialogue, really try to move away from verticalized programs and make sure that the programs are really integrated into the health systems. Now, where is Ghana in this process? We see that Ghana has come up with a lot of policies and plans, and these are many of the policies and plans, from health financing to quality of care to primary health care. And Ghana has made a lot of improvement, as highlighted by the DG. In terms of outcomes also, we see a very positive trajectory for Ghana. All the child mortality indicators are going towards the south, which is good. Good trends in antenatal care and then child growth indicators as well. Now, in terms of health financing also, as the DG mentioned, the domestic financing is really improving, pushing away out-of-pocket expenditure and then development assistance. So what needs to be done at this stage for Ghana? And I group this into three. We still have the legacy agenda, because even though Ghana is really moving towards the last stage of the transition, there are still issues to be dealt with, which I group this into the legacy agenda, addressing MNCH, promoting equitable access, because even though the indicators are good overall, there are some regions that are lagging behind. And then also paying attention to quality. Now we have to also think about the middle income agenda. Where do we want to move the country to? And here we have to expand coverage of insurance and then also go into innovative health system reforms like the network of practice, which has already begun. Whilst doing this, we need to think about ways to safeguard against that we've made so far. If there's another pandemic, will the country lose all the gains that has been made over the years? So we need to focus on ensuring emergency-ready primary health care system and adapt health system for climate vulnerable future. And then manage net HRH migration, especially this time where there's a lot of issues on HR migration. And then R&D, research and development, is also key at this point. My final slide, at this point, what can development partners do better? There's the need for a comprehensive approach to donor dialogue. There should be a comprehensive costing of all programs to make the government understand what sort of responsibility lies ahead of them in the times of transition. Development partners need to help the Ministry of Health, to really make investment case on the cost or impact of essential services that they want the country to fully take charge of. We need to gravitate towards on-budget donor support and reduce more direct financing to facilities and districts. We should cut down considerably on financing of recurrent expenditure, as I said, and use country-led resource-based instruments to identify residual health systems. So after we've supported the country for a very long time, now we need to sit back and ask them to lead, and then we watch them from behind and ask them to generate results by themselves. And in this process, we will be able to identify some weaknesses in the system and then address them. These may be things that we may have missed out in the first, second stages, but then we find out in the last stage because they are fully in charge and we are not hand-holding and we are not providing a lot of support to the system. Now, the domestic resource mobilization agenda has to continue to fill in the gap that will be created with the exit of donor funding. And then we have to, and this is very important, the last 2 points, encourage South-South cooperation. Once we see that Ghana has become an exemplar, we need to be able to showcase what Ghana has, and this has two impacts. to let them understand the responsibility they have as, a leader in the region, but also to use the Ghana experience to also bring up other nearby countries within the regions to the status of Ghana. And then again, invest in health systems efficiency interventions, because at this stage, once donors are leaving and we are avoiding out-of-pocket expenditure, the system has to be super efficient so that even the little domestic resources can provide more health for the country. So my takeaway message is that the transition period is not just 2 blocks when countries move from lower middle income to middle income. It's a full process. And it has to begin very early on, even when countries are at the very minimum process. And then we shouldn't see it as just one process. They can be grouped in phases. And based on where the country is, we have to tailor development assistance to be able to achieve the best out of the system. And then we have to be flexible along the process. Thank you very much.
Thank you, Ochi-san, for sharing your view on the transition. And your phased description was very clearly explained, I think. And it will be a kind of guide in our discussion. Thank you very much for your insightful presentation. Next, I would like to invite Dr. Akiko Hagiwara, Senior Advisor of JICA. She has been working in reproductive and maternal neonatal child health field for many years around the world. And in Ghana, she has been continuously engaged in maternal child health record book development and its integration to Ghana National Program. She's also a member of investor group of GFF as JICA representative. So, Akiko-san, the floor is yours.
Good morning to everyone. Thank you, Madam Chair, Makimoto-san. My name is Akiko Hagiwara from JICA. I'm the Japanese, but I dress like Ghana. And I have my Ghanaian name is the Ajwa. Yes. I'm very honored to talk about the Ghana experiences, particularly the maternal and child health record book projects and the program it's now. It has been the JICA project, but now this book is owned by the Ghana government. And this is the program, really the transition from the donor support to the exiting to the program itself by the national government. So I'm very honored to talk about these programs. So I have 3 issues to talk. A major achievement of this record book first. Then I'll talk about the transition from project to the national program. Then we want to discuss the key factors promoting the transition. So the book has been developed in 2018 by Ministry of Health, Ghana Health Service, with the support of the JICA. And it's a home-based health records for mothers and children. And it keeps the records of pregnancy, delivery, after pregnancy, and child health. And it contains the health and the nutrition messages as well. So this is the record, and this is the message books for the mothers and caregivers. In Ghana, we have trained more than 3,000 health workers on the effective use of the maternal and child health record book for the health services. And also, this has been, as DJ mentioned, this has been utilized in all health facilities in Ghana, including the public, private, and even NGO facilities. And it improved the communication between health workers and mothers, and also improved the positive experiences among mothers, because the book is designed for mother to understand and for family member to understand. It improved the mother's knowledge, practice, and now, as I said, technical, financial sustainability is established, and it's all owned by government of Ghana. So this has been, we have been utilizing many different home-based records before the book is introduced. So we had the mother's book, child book, and COC cards, and all these are combined into one book, and we made more effort to make it easier for the family members to understand so we can change the behavior at home. As the DG was mentioning, that this is a sustainable mobilization of the motivation mobilization tool in Ghana. It has the records and ID. And now in Ghana, this ID is utilized for the national health insurance ID and also the passport. This is the birth certificates. There is the pages for the birth certificate page also. And the baby can carry it for the life as the birth certificate. So it's an ID. And it's beyond the health service. It's the booklet used for the civil services. And also the information, like you see the many pictures in the book. I will show you the pictures. So these are illustrations, the messages are designed for the mothers and the family members to understand. These are the record pages. This is orange for the pregnancy care, yellow for the delivery, blue for the newborn, and the green for the child care. This is the color-coded. And to make easier for health workers to fill, and this is the efficiency that we designed. So the introduction of book can be the burden for health workers to start the new recording. But we try to reduce the burden and make it easy for the health workers. So it's color-coded. This is the blue page. So this is the newborn care page. And we have contains a lot of health information and messages with illustrations. So even the illiterate mothers can understand the messages, which is for the equity and also the strengthening of the primary healthcare services, approaching to the most vulnerable populations. In Ghana, the English is spoken and understood by many people, but there are many people who do not speak English as the mother language in Ghana. They have 20, 30 different variety of languages in Ghana. So the illustration, and also we need to train healthcare providers how to explain the contents to mothers and family members. So we took care of the training of the healthcare providers on how to use this book. So you see two pair of the community health nurses are teaching mother on what is written in MCH record book. Now, the one is explaining the book, the contents of the book. Other one is having the checklists. And this is the training that we train counseling skills. And the pair of health workers are doing the role play with the real mother to practice how to explain mother effectively. So as the result of this training, now 92 women and children completed all ANC 4+ skill bus attendant delivery and also the postnatal care in model sites. So this really, increased the coverage of services. Also, 83% have records of births and birth weight. This is the statistics nationwide, not just in the model sites, but nationally. Now, the birth records and the birth weights is written in the book. So that is why the book is used as the national health insurance file and also the ID, the national ID. 81% pregnant women and mother receive nutrition counseling. Like this counseling, you see the eye-to-eye contacts of the health worker and mother, and really they are communicating with efficient way. And then 96% of them says that they remember the messages. Now the transition of the project to the national program, the JICA supported the research, pilot, and also national rollout of the MCH record book. Then that was transferred to the national program. The MCH program is now sustained by the government of Ghana. You see the leadership and the policy decision started from the very early stage of the research. I mean, to start with, the research was owned by the Ghana government, not on the JICA. JICA was there to support And also University of Tokyo was there to support, and that was owned and made a decision by the government. And the project was supported by JICA technically and financially, but in the middle of our national rollout, the domestic resource mobilization also started. And the coordination, coherence, and alignment with the development partners all through these processes, because of the leadership of the Ghana Health Service and the Ministry of Health, they invite all DPs to discuss together for the national rollouts of the booklets and use the booklet for the primary health care strengthening. So this is the transition pictures. In the research, it identified a feasible effective intervention package. And in the pilot, we developed a booklet and we tested the feasibility. In the national rollouts, we did nationally the capacity building, monitoring, but not only capacity building, we did the health systems training thing at the same time. And we did also pay attention to the coordination with DPs all through these projects. Then this was owned by the national program now, the government owned, and they have our capacity building. Now the JICA conducted training with JICA budget, but as they exit, now they put this training program into the in-service training into the pre-service basic training, and also on-site training, so that you don't have to need a big budget to continue the training program. And the book is expanded, the value of the book is expanded to the civil service and vital statistics, and also insurance system. As a result, the Health Insurance Authority and also the Birth and Death Bureau is printing 100% of the booklets. Or now the 200 and 300% of the coverage of the booklet is printed in Ghana by Ghana government. So there is no shortage of the booklet there. So I want to talk about the booklet. Now the JICA exiting from the Ghana government. I mean, the JICA project finished, but the booklet is continuously supplied by the government of Ghana, a big amount, to deliver services to all children in Ghana. I can't talk in details because of the time is finishing, but to start with, 2017, only JICA was printing the booklets. But 2023 and 2024, everything is covered by the National Health Insurance Authority, Birth and Death Bureau, and the also regions and districts, which means that the government of Ghana is covering all booklet. That they need only 1 million books, but they are now producing 2.5 million books, or 1.2 million books, which over producing the booklet to be utilized for the training, to be utilized for the National Health Insurance file, and even to fill the gaps where the books has not been delivered. So finally, this is the final slides. We think that the key factors for promoting the transition is, number one, the country ownership. And we're very honored to have the very strong country, working with the very strong country ownership, such as Dr. Boaje, and also the ministries have the very good, big leadership. And the JICA and DP are just filling the gaps in the health system. And meeting the needs of end users. Of course, we try to meet the needs of the mother and family members, healthcare providers for the efficiency of the service, and health administrators. And we take care of the equity. I talked about equity. The book is designed for the equity. And the book is distributed to all babies at all health facilities with the simple, standardized health information and messages. And the PHC is strengthened, and we took care of the coherence with the global and country strategy and priorities. Finally, the alignments were there from the very early stage. The DP were all involved from the initial planning or stage of the MCH record book. And DPs also use these our training packages for their own programs, like UNICEF is conducting their programs, and they take care of the booklet training, utilizing our training materials. So it's all planning were there, alignment were there, coherence were there, which is the under the Lusaka agenda. So I share these experiences with you, that maybe this is the good example for the neighboring countries, other countries, to go through promote the Lusaka agenda and to strengthen the country ownership alignment and exiting from the donor project to the national programs. Thank you.
Thank you, Akiko-san, for sharing the picture, landscape of MCH record book in Ghana, which started from a project, a research project to a national program, and your observation of the successful key factors. It was very insightful. Then I want to have the last speaker, Dr. Akira Shibanuma, lecturer of the University of Tokyo. He is a global health researcher with specialty of public health and applied health science and development economies. He has been engaging in various researches in low-middle income countries, including Ghana, and played a key role in JICA implementation research project of maternal child health care COC card in Ghana, as Akiko-san mentioned. So, Dr. Shibanuma, the floor is yours.
Thank you very much, Makimoto-san, for your kind introduction. My name is Akira Shibanuma from the University of Tokyo. So I'd like to talk about the role of academic research on the transition of the great MNCH project to as a national program. So yes, we recognized the big problem in maternal, newborn, and child health when the project started in 2012. So yes, coverage of the key services improved. Antenatal care 4 times or more, or skilled birth attendant delivery. However, mortality figures are not as satisfied. Then, so Ghanaian researchers, so under the leadership of the Director General of the Ghana Health Service and the Director from the Research and Development Division of the Ghana Health Services, together with the University of Tokyo and other researchers, talked a lot about potential interventions. And one key is the continuum of care. Yes, it was actually validated in the formative research done in 2013. Yes, the key services, antenatal care and the skilled birth attendant delivery was good as national figure presented. However, when it comes to postnatal care, the gap was clear, especially within 2 days of delivery when many of the mortality occurred in the risk period. Therefore, so we need to address this gap. And what is an intervention? So it can be done. So it is what we talked a lot. And as Dr. Bourget kindly mentioned, so yes, the research is the product of the co-creation between Ghana and Japan, and inspired by the ideas of maternal child health handbook, record book. Actually, the left one is my own record, so I still keep it at home because I need to check my vaccination record, my kind of complications, and so together with my brother's some complications, it was really useful to understand my own health at the age of 50. So, and so now, there is a fancy MNCH handbook. So this is an example in Yokohama. So bringing Japanese idea, but creating the intervention together, so between the Ghanaian researchers and Japanese researchers to present this idea. So since the gap is in the 2 days of delivery. So we need prior interventions for the COC orientation for health workers and distribution of the very simplified one-page, what we call COC card, to record key services and visualize the achievement. Together with that, so that we advocated 24-hour retentions at least at the health facility after delivery, plus the home visit postnatal care in case of the home delivery. Then yes, this is the COC card. So it is a kind of the innovation in many senses. So clearly visualize all mandatory visit and services component in maternal newborn child health care. And it is used for birth preparedness, breastfeeding, family planning, and it records complications as a checklist. So this is a kind of the service level agreement between pregnant women, mothers, and health workers. So what kind of services we can receive, what kind of point we have to address when the health status is not as good. Then so we did a real-world impact evaluation. It is very important because the card is used in the real-world setting in the national rollout. So the intervention, so beyond the kind of the laboratory-based or kind of the very beautiful randomization, we little bit, so beyond that, so to take advantage of the health services done in the routine care. And we actually intentionally allowed contamination of the intervention between intervention area or control area because mothers, pregnant women actually have an autonomy to select any facilities, including going to hospital or CHIPS is a primary healthcare facility in Ghana. Then as we achieved the improved coverage after the intervention, so around 47% on average of the what we call continuum of care completion, having all of the interventions above. And yes, in addition to that, so we have a partial evidence of the reducing the maternal mortality. So intervention period was not as long as desired. So mortality figures are limited. However, it was promising direction. So together with the reducing the maternal complication during pregnancy, which required hospitalization. So in addition, so we did real world analysis. So yes, we improved coverage of services in the intervention area. In addition to that, so we achieved the improvement in the control area when where the mothers lived near the intervention area. That means so that they may go to the intervention facilities. So that's very promising. So the national program is ongoing. Then when the national program starts, then so they can proactively choose health facilities for the good health care. And one very nice result is that, so in addition to the public hospital, which is very good in quality, then so community level health facilities is a very nice place for the improvement of the continuum of care coverage. So these real-world analysis actually push us forward for the national rollout of the COC program. So this is a final slide. So for the successful intervention, yes, we had top-level government officials and researchers and motivated health administrators were in the project of the research. So then, yes, we have experienced technical assistant team, so in MNCH from JICA and then Japanese consultants as well. Then, so we have very nice task sharing between the researchers from Ghana and Japan. And yes, choice of the intervention created kind of the excitement among women, family, health workers, and health administrators. As Dr. Hagiwara mentioned, yes, new intervention may incur additional burden. However, this kind of intervention, COC card, can reduce the burden of the health education. So since it is visualized, so it fosters communications within the family between women who receive the instruction and other family members. So we had qualitative research, so evidence based on that. So together with these so good aspect of the intervention, so we have confidence so for the COC card intervention for improving the coverage of the MNCH services. So that's everything from myself. Thank you very much.
Thank you very much, Dr. Shibanuma, for insightful presentation on the case of the research, which start from the pilot, very inclusive process of discussion between Ghana and Japanese researchers. Then it became to the national program. Okay, so now we have 4 speakers at front, and we'd like to invite 2 panelists. And first, I would like to invite Dr. Kalipuso, is the director of health financing WHO. But before that, she was working as a global fund, and so she is another expert of Lusaka agenda. So you will give us some maybe summary of Lusaka agenda and your comments from your expertise. Thank you very much.
Thank you. Thank you very much. Good morning, everybody. So yes, there was a question actually on the Lusaka agenda, and if I may very quickly try and summarize it, but also to say that there is, if you Google it, Lusaka agenda and FGHI, Future of Global Health Initiatives, it takes you to a really nice website with lots of resources. But it's what the Lusaka agenda is about, I think, was a sort of a multi-stakeholder initiative which brought together different groups, the global health initiatives, the Global Fund, Gavi, GFF, the World Bank, but also civil society and countries which give development assistance, countries which receive development assistance, and different stakeholders. And the idea was to think about effectively moving towards aid independence. And they came up with 5 shifts, and the DG showed them, I think, in one of his slides. Focus on primary healthcare and integration services, including through community outreach. That was the first one. A particular emphasis on domestic resource mobilization, and talked about this, how important it is for countries to commit their own resources in order to achieve programmatic and financial sustainability. Focus on reaching the most vulnerable, excluded populations. The fourth one was about coherence and alignment between the GHIs, so how can they work together and stop distracting governments, rather help them improve their own efficiency in their operations and help governments engage with them better. And the final one was about science, research and development, and also local domestic manufacturing. And there were some short-term actions recommended, including, for instance, adopting common metrics on health system strengthening or the way money flows, and moving us towards the sort of the one plan, one budget, one report, M&E report, and sort of following on from previous initiatives such as the Paris Aid Effectiveness Agenda, etc. So it's worth Googling if you haven't heard of it, and I think it's really great to see how such an initiative has now become internalized, and as DG mentioned, also AU has adopted it. And engaging in it. Okay, so my comments. Chair, I was asked to talk about a little bit about, so what can development partners do and how do we move out of aid dependency? The first thing I wanted to say was a few months ago, I was talking to some colleagues from UNAIDS, and they were citing some really interesting statistics, because a lot of the time when we look at averages, aid is actually a small fraction of what especially African nations spend, right? But if you look at individual diseases and conditions, there is quite a bit of dependency. So what the UNAIDS colleagues cited in relation to HIV is that when you take low-income countries and the total health expenditure, about a third of it is aid, development assistance. But when you look at HIV, over 75% is external money. And then when you go to lower middle-income countries, there ODA is a very small fraction of total spending, it's about 4%. But if you look at HIV, it's over 30% again. And even countries such as Indonesia, for instance, which recently took out a huge loan of almost 4 billion for health, including from the World Bank and other MDBs, even there, when you look at TB and HIV, there's significant dependence on donors. So I think that's where the risks are as countries are thinking about transitioning out of aid. And how can that happen? I mean, transition, of course, can be triggered by the money dropping, right? And we know the current political environment, there's a lot that can happen. So you can have a significant reduction in aid. And that's not the right way to do it. I think that creates a lot of issues. So we need to find ways in which this transition is triggered, not by macro effects, as our colleague from the World Bank mentioned, because these don't necessarily reflect the situation in countries. But nevertheless, we need to force ourselves, because there's incentives both within countries which receive aid and within countries which give aid and within global health initiatives or even colleagues in the World Bank, right? I mean, you want to be there and give. That's part of the business model. And so how does that, it's not going to happen spontaneously. So how does it happen? We need to trigger, we need to force ourselves, and that's where the governance boards of these initiatives play an important role. Force ourselves to fund through government-owned channels, at least in the first instance, which means stronger public financial management systems. This is not, again, going to happen spontaneously. The Global Fund has been around for a long time, and systems haven't necessarily strengthened because it's been around. So it needs to be an intentional effort, channeling the money through the country systems, and having a stake, joint stake, as we saw the joint project with the book, joint stake in strengthening those systems so that they work. Altering the power dynamics, I think increasingly, I think it's perhaps more important how the money flows rather than how much money is channeled through different systems, because the way the money flows determines all these power dynamics, creates winners and losers, creates people and institutions who are in control. And changing that is difficult. Also, as you said, focusing on intentionally pulling out of funding recurrent costs, human resources for health, commodities. We've seen in several countries where Global Fund or Gavi have gone back in, started to buy vaccines again, started to buy antiretrovirals in middle-income countries. So that needs to push back against that. And then ensuring synergies, so forcing donors, forcing those institutions which channel funds to work together. So Global Fund, Gavi working together with the World Bank. And I'll finish just by saying one example with Nigeria, for instance, and the swap, which is an interesting development under Professor Pate's leadership. And I think that's where we've seen Gavi, for instance, pull its funds, it's recently announced, with the World Bank and others. And to finish by saying that Professor Pate and Nigeria is tabling a resolution for the next World Health Assembly, which includes the Lusaka agenda and talks about health financing for UHC. So it'd be wonderful to have Ghana leadership also support, because we need those voices also, the World Health Assembly, to increase the accountability and hold people and institutions and countries to account. Thank you very much.
Thank you, Kalipso, for very insightful comments. So Kalipso mentioned about Dr. Pate from Nigeria. I want to invite Nigerian commentator, Mr. Felix Obi. He is a country director of Research for Development in Nigeria. The floor is yours.
Good morning, everyone. Konnichiwa. Yes, I'm a former JICA staff. So I started development work in JICA. So JICA is very dear to my heart. Yes, in 2005, I worked with JICA till 2010. Now, she mentioned Dr. Pate. I'm not Dr. Pate. But he's our boss. He's really a breath of fresh air. And So Calypso has already mentioned swap. So Nigeria and Ghana are brothers. We don't only fight about jollof rice. We are also we're also trying to transition out of donor aid. And interestingly, Ghana started first as middle income to some extent before us. But we had oil before. We've had oil for years. So how come the economy was bigger than us? So we had to rebase in 2014. And as we did the rebasing, we realized that our donor aid had to go. so kind of aligned with what he said. So for us, when Dr. Ngozi Okonjo-Iweala, that's the DG of World Trade Organization, WTO, when she rebased our economy as she was the coordinating minister of finance, she didn't realize that she was also shooting the health sector because the health sector depended heavily on donor aid. For HIV/AIDS, with our big population, we were not really funding as much. And then immunization. So Gavi, our transition, it had to, we were supposed to transition almost quickly from Gavi. Calypso can confirm. So we had to renegotiate because our co-financing was supposed to be huge and all. So there's a lot of countries like Nigeria, we were not planning for transition, but we realized that we had to do that. So over the last 10 years, we were struggling in many ways because donors have a lot of influence in Nigeria. So he mentioned that when we do the national health accounts, you look at the development aid contribution is very small in principle, but to a large extent, the impact, especially the vertical programs, service delivery and also, that is where the donor funding and support has been focused on. So now, Nigeria, interestingly, had also started thinking of ownership of our health sector. So in 2014, we had a presidential summit on universal health coverage. So we adopted the UHC charter for Nigeria, where we gave it was agreed that we will reach a target of at least coverage about, I think, 30% by 2020 or thereabout. But of course, we haven't achieved that all this while. Then in that same 2014, our National Assembly, that's the legislators or Congress, as similar in US, passed an act called the National Health Act. So the National Health Act is the first legislation for health. So in our constitution, health is not a right. There's no coverage of health in our constitution. So to kind of provide a legal framework for all the health reform policies and agenda, that law was signed into law by our president in 2014. Then that law, there are two key provisions I want to mention. The first provision is that every Nigerian should have access to a minimum package of healthcare services, like basic healthcare services, at no cost. Then to finance that, the same law made a provision that at least 1% of the consolidated revenue, or the revenue that comes to the federal government, will be used to fund that. So, like policy provisions backed by law, and then the financing. But it wasn't just easy like that. So I was part of the advocacy for that law, but that law took 10 years for it to be passed. So it started way back in 2004, and then it was passed into law 10 years after. So this is 2024. I can tell you that the implementation has not been easy because I've been involved. So translating policy to action is a whole lot, especially public policy. But I will focus on, in terms of, I know I have a short time, so I will focus on some key things in terms of our transitioning. So I will use the WHO pillars just for clarity. So in terms of policy, so we have the National Health Policy 2016, and the focus is on universal health coverage. So how do we achieve universal health coverage? But we have other sub-sectoral policies like the health financing policy and strategy, which outlines how we will finance UHC and all. And we also have like the human resources for health policy. So we address some gaps. For instance, we have what we call tax shifting policy because we realized that health workers are not fairly distributed. We don't have skilled bed attendants in all the primary health care centers. So we had to have that task shifting policy to address some of those gaps. We are not there yet, but at least these are some policy frameworks that are there. And in terms of domestic resource mobilization, in addition to the National Health Act, some states too have had to set up their health insurance agencies because Ghana and Nigeria started about the same time, but Ghana's coverage was improved so fast, but ours plateaued. So in 2015, we adopted a decentralization of health insurance policy so we have 36 states, we see them as 36 countries in one within the same Nigeria. So all the states now have their state health insurance insurance agencies. And interestingly, we've had marginal increase from Dr. Lee, she knows Nigeria's story. So over the last 2 or 3 years, the state health insurance agencies have pulled in a lot more lives than the National Health Insurance Authority had done for almost 15 years. So you could see that twisting the policy a bit can help change the story. Now, within that broad policy framework, we now have, so Dr. Pate that she mentioned, Dr. Pate he was a former Minister of State, that's the junior minister in 20, okay, my time is up. So just give me just 2 minutes. Now, so for country ownership, swap, so the sector-wide approach. So in December, the president signed a compact with all the state governors and development partners. They agreed on specific results, what they need to do in terms of financing and all. So we have that, and there's a whole lot happening. So 2 weeks ago, on the 6th to 8th, we had the first sector-wide approach joint annual review, where we review the health sector, where are we and all, and a whole lot of things have come up. So to address NDHS, the demographic health survey just came out for 2023-24. The results are not so good. So one of the areas, still maternal mortality is still an issue, child mortality. So we launched a new initiative called Maternal and Newborn Mortality Reduction Innovation Initiative. So the idea is there are about 100 and something local governments where the burden is higher. So the focus is to now target interventions in those areas, include some innovation, some all. And yes, that's for services. So for financing, the president made a pledge to expand coverage to 50 million poor and vulnerable Nigerians. So the National Health Insurance Authority is working tirelessly to expand that coverage. And in terms of the supply side, we just did a mapping of all the primary health care centers in Nigeria to kind of identify them where they are so that people can recognize where there is comprehensive maternal and child health care services available, so that if a woman is pregnant and needs services, they know where it is within their locality. And then we're also training about 120,000 health workers at the primary care level to upskill them and all. So in a sense, what good thing is that taking ownership, because to start the swap, donors found it a little bit, it was a shock because the minister said, you either align, we either have one plan, one budget, one M&E framework and all. And just to wrap up, between August and September, all the donors, we now supported all the states to develop their annual operational plan for the first time. So we have one unified annual operational planning, and then donors mapped their funding on what specific interventions they are to fund across the state. So this is the first time it's happening. So I'm hoping that we'll catch up with Ghana and maybe overtake Ghana. Thank you.
Thank you, Felix, for sharing the Nigeria experience and comparison to Ghana. So we have only 6 minutes left, but I'm sorry that my time management is poor. But I would like to invite Dr. Patrick for your reflection to the four speakers' presentation and to commentators' comments.
Yeah, thank you very much.
I have one question to you. sorry. Let me read. I'd like to thank all the presenters for your insightful presentations with a lot of actual good practices happening in Ghana. I'm now missing She was in Ghana, yeah. I was very much impressed by Mr. Ochi's strong message regarding how DPs can do better in the transition period. I'd like to hear from DG Patrick, as a great health sector leader in Ghana, on how DPs can work better to make the support more effective, efficient, and sustainable, particularly in the transition period, like current Ghana.
Yeah, because of time, I actually skipped that. One of the key strategies is donor coordination. It can be very, very complicated. It can really be disruptive. There's turf war among partners. There is virtually not allowing even domestic resources to be used because they want to spend their money and have a high burn rate. So these are very, very critical areas that we need to look at. And so what we do is we insist that there is a national plan. And I believe that the most important is to have a plan before partners come in there with their plan. If you have a plan, then you align them. And I think by and large, having a plan, aligning them, and also allocating geographical zones for them and ensuring that they work together is something that helps. We did that to the extent that 3 partners had to agree that let's fund an MOU so they can work without necessarily crossing over each other. So I think that donor coordination is extremely, extremely important. But my general reflection on the presentation shows that clearly local knowledge is important, local involvement is important, and that as we look at in terms of transitioning into the middle income or donor pulling out, we need to ensure that we have equity is addressed and that we don't leave, like someone said, 9 plus 1 is 10. The average is 5. But someone has 9, one has 1. How do we look at the people who have 1 and not making think that they all have 5? And I'm happy with what Otis' presentation. That takes care of all those gaps. And obviously, in terms of local leadership, can provide results. And I'm happy that I was part. We had a lot of quarrel with Akiko. He wanted to do a pilot. I said, no pilot. Either we do it or you go. And he went back to Japan, came back, and we had a rollout. And now we have a wonderful product that serves as a good example on how we can work together to deliver good results. Thank you.
Thank you, Patrick. It's a wonderful reflection. We learned the importance of donor coordination, local knowledge, local involvement, and the leadership. How we can work together. It's very important key message. We'd like to share to not only this meeting room participant, but also all the global health stakeholders. Yes. Is there any speaker who would like to talk? If not, I would like to invite maybe one commentator from the floor.
So thank you very much. My name is Labran Musa. I'm from the Ghana NCD Alliance and also from Ghana. And indeed, I'm very happy about the presentations. You all agree with me that over the years, there has been challenges in terms of health promotion, and donor funding has always considered on other things, leaving health promotion and health prevention aside. And I also agree with me that I think in recent times we've seen that countries in Africa also increasingly increasing taxes on health commodities. I've not heard anything about earmarking or soft earmarking to support some of these interventions that we are going to roll out. Is this something that we want to consider as we move along in this journey? Thank you. Thank
you very much. Do you want to say something? Yeah. Okay. What's that?
Thank you very much, Mr. Labran. I think that's an important question. So indeed, I mean, as a health economist, I see generation of taxes from, alcohol, cigarettes, sugar, beverages as a very important intervention. First of all, to reduce the NCD burden, if it works. And then second, to also, of course, raise funds. Where I tend to deviate a little bit is when it comes to earmarking, because at the Ministry of Finance level, best public financial management principles do not necessarily encourage a lot of earmarking. It's like you are a father and you have children and you have a certain amount of money, and then you give some of the money to your children that put this money in your pocket. Nobody can touch it. At the same time, you need money to provide critical needs in the household. Now, your son keeps the money until the end of the year, maybe sometimes 2 years unused. Whilst you needed a lot of, you needed some money for critical interventions within some point in time. So at some point, you decide to pull everything together. And based on the need, you provide to the household. So this is how Ministry of Finance see, its sectors. And so if you want them to earmark all these taxes, it becomes a bit difficult for them. However, once these taxes are raised, the health sector gains in the first instance of trying to control NCD burden through these taxes. Number two, we tend to have this increase the fiscal space for the government overall. So if government has $1,000, now has $1,001 to be able to, so you can advocate for more allocation to health based on these taxes without necessarily going on the earmarking tangent, because in most cases, it doesn't work. And that is my, my experience and, my opinion as a health economist, and what we've seen in many other countries where we try to even promote, earmarking, and it doesn't really work. So take home, let's still have health taxes because it will help us reduce the burden. Number two, because it is contributing to the overall national revenue, we can then approach the ministries of finance and make a case that, for example, in Ghana, there's health taxes being generated. And so in our next budget, please try and allocate more to health because you are gaining more from health. There is even a COVID levy, which the government is taking in Ghana. So why don't you, Dr. Selby is looking at me, why don't you give us more money? So fill in the hole. Instead of saying that this money is for me, so give it to me, I think that's a bit tricky, in my opinion.
Just to add, there's another angle that I didn't look at. It's also domestic production. See, if that is to encourage domestic production, then that's also good. That attacks the shift 5. And that is why, despite the taxes on imports, you don't have the same taxes if they are produced in country. So I think that's what we also need to look at. That apart from that, we also need to create jobs and also improve local production.
We'll talk about this maybe after the session.
I'm sure you wanted earmark for NCD.
Let me tell you, funny story. So in Ghana, UNFPA wanted some earmark funds for, FP commodities. Gavi wants earmark funds for, vaccines. Global Fund wants earmark funds for HIV/AIDS medicines. So at some point we had about 5. I've forgotten the rest, 5. And then they wanted the World Bank to sort of lead the discussion. And I said, I'm not going to the Ministry of Finance to tell them to have 5 earmark, funds. The budget, it's not even possible, to prepare a budget sheet with earmark funds for about, what about the other sectors? So we also have to understand the constraint within which the Ministry of Finance, work and a bit manage the expectation.
So at last, there may be Akiko-san and Shibano-sensei, just a few words only, because already we passed the time. I'm sorry.
Okay, just a few words related to the question NCDs. It's and health promotions. Is this on? Okay. Yes. We are also contributing to the NCDs and the health promotion, starting with the MNCH as the core. And this is, I'm the MNCH experts, but we were contributing to the whole picture of the life course approach. And I think Ghana is in a good step to expand MCH experience to the life course approach, including the NCDs. Our task as the donor, we will not projectize our projects. And the research project needs the target areas and the intervention sites and the control sites. So we are limiting the sites. But once the result comes, evidence comes from the target or the control areas, then our task is the expanding the result to the national program with the national budget and exiting from the project to the program. So I think I really wanted to say is the donor should not limit the target areas, but we have to work with the national strategy and national plan. So the project is not just for the target areas. So that's what I want to say. And MCH is not just for the MCH, but we are contributing to the life course. So the big picture needs to be shared with the government and all donors and the partners together to support the transition. That's my words.
Yeah, I fully agree with Dr. Hagiwara for the life course big picture. Yes, maternal health is a great window of opportunity for health promotion for a longer term, not only birth and children. So then in addition, we need good integration. So for example, integration of health promotion with health insurance scheme, for example. Health insurance is a very good opportunity for health promotion because they keep track of expenditure. They really want people to be healthy for the effective and efficient insurance pool. So like in Japan, we integrate the health insurance scheme with the NCD promotion, detection, and treatment. So yes, I'm actually detected with some risk of NCD through the annual checkup, promoted by the insurance scheme. So we need great integration. So this is kind of the comment from myself.
Yes,
Rio last.
I think a lot is happening as far as this health promotion is concerned the last 2 years. One is the launching of the health check, annual health check sponsored by the health insurance. The Ghana Health Service and the ministry has established wellness clinics. So far we have about 800 across the country where you just walk in, receive information, education, and some testing if you need to. So I think we are pushing for that. We are currently doing a pilot with health insurance to see how do we pay for promotive and preventive services. So I think there's a lot happening in that front. And I believe that we all be very happy once it comes together. Thank you.
Okay, so thank you very much for everyone. This is the end of this session, and we got a lot of very important take-home messages, key take-home messages. So we want to continue the discussion, maybe inside JICA and with other stakeholders. So please give a big round of applause to all the speakers for their wonderful and insightful presentations and comments. Okay, thank you so much.